So, hey everybody, this is Gene out of the FHIR podcast. And today I have with me Paulius Mui. Am I saying your name right?
Paulius Mui, yes.
Paulius Mui, yeah, which is a very cool name, by the way. And the way we met with Paulius is through Health Tech Nerds. So Health Tech Nerds is a community kind of chat room in health tech. And if you're a part of it, you know there's a lot of very interesting people on there, and they post about all the different things that are going on in health tech and startups. And particularly, Paulius, you've been posting some very awesome content on primary care on LinkedIn and other communities. And I thought it would be a great opportunity for us to chat and connect maybe the FHIR world with the primary care world and see what awesome things are happening in the space and how you kind of perceive where we are, where we're going. A lot of the audience for this podcast is very heavy on like FHIR interoperability, health tech, but I think it's really anyone. So feel free to, get as technical or not as technical as you want. And honestly, just feel free to kind of describe your platform. We can start just by learning more about you and how'd you get into this and where you come from.
Yeah, I appreciate you having me on. So I think it's a great thing you mentioned HTN. It's how I got started in health tech, like 4 or 5 years ago. I was a resident and kind of came across this world where people were building things for healthcare, and it's pretty isolated from, or I would say actually the healthcare clinicians are pretty isolated from the business ecosystem. And so it was so new to me. And so I started learning that there are all these companies out there, solving problems and doing stuff. And HTN is how I got started. And it was like a couple hundred people by the time I joined. Now it's thousands. I think it's like over 5,000 or 6,000.
Like 4,000, 5,000. Yeah.
Yeah. But I just actually traveled to different cities and hosted events. Pretty much every city channel that HTN had, I went and met people, and that's continued to do that over the years. And that's how I built up my network, how I learned about what's going on at the intersection of technical and clinical worlds. And then I'm a big advocate of primary care, so try to bring forward the problems that are worth solving in primary care. And that's something that I think, doesn't always get talked about. So I enjoy doing that. I can give you my background a bit as well, if that's helpful.
Sure.
So, I family physician, I run my own practice. I also have my own company in health tech. So have worked with engineers for years, product folks, and being that interface, I think, between the clinical and technical worlds is what I really enjoy doing. And so I'm these days focusing a lot on solving problems in workforce quality and how can we make people better who deliver care. I think that's a really interesting problem space. And from the data perspective, we just don't have a lot of visibility and insight. Like, who's a good clinician? When you go get care, how do you know that that person taking care of you is the best person to see you or your family?
Yeah, awesome. I got to say, I have met some folks that are kind of similar to your background, and I know a bunch of physicians in this space, and I got to say, it's hard and super my hat's off to you to be able to pursue your passion on the technology side and drive, innovation as in addition to being a fully practicing clinician and having gone through, medical school and done all the training. First of all, how were you able to do that and success? And what would you say is the biggest bottleneck in that process of you being able to actually find the time to do this and see patients still?
I would say, I start out from a place of inquiry and I just started writing. So most people feel like they need to be an expert to put out something out there, their thoughts. I really start from a place of question asking. And I think that, having a beginner's mind is really forgive for you asking simple questions. And I think I can go a long way. And so I just learned by, writing, blogging, people would reach out, would have chats. I mean, it's kind of how you found me, right? And I also then started working on real world projects. One of my first jobs out of residency was building out an innovation team for a private group. We had almost 50 clinics. And so the scale was fairly sizable, and we had to kind of redesign our own EMR. I built a bunch of back office, front office tooling. And so when you have real problems to solve, don't have an excuse not to do it, basically, right? Because technology touches patients and people who take care of patients in so many ways. And so I think that part is just how I got lucky, got into a role like that, and learned a lot on the job. And then part of that role was telling engineering folks like what problems we have on the clinical workflows and operations, and then having a lot of the conversations on how to solve them. And I just, realized that feedback loops in healthcare are pretty quick, and that's really rewarding. Like some engineers, I guess outside of direct to consumer ecosystem, like some engineers are used to working in places that they don't see the impact of their code, for a long time. And the place we were at, you could basically ship a feature and, have like hundreds of clinicians change how they go about taking care of patients, which was pretty fascinating. And then that got me curious about coding. And this is really before and vibe coding took off. So I learned the traditional way. And I remember a couple of times when just being in clinic, I would be able to ship some feature in production and utilize it on patients in the second half of my shift. And so I think that's pretty cool.
That's awesome. I guess in healthcare, but probably in every area, the closer you are to the problem, the more motivated you are, and more motivated your engineers are to solve it because they actually experience it. So it's like if you're working in a space where you experience the problem and then you're motivated to solve the problem, the results of that will be probably a lot better than somebody that's kind of like you have to create a large problem statement and a whole structure of vision, strategy, PRD documents. You still need those things, but if people feel it themselves, I feel like they will find solutions that nobody has even thought of, right?
Yeah, totally agree. And I think that these things happen when you have the luxury of time and when sometimes you just need to get things done. You iterate, and sometimes you don't get to QA everything that you need to QA, and you get to learn just in the wild, which is, exciting, terrifying at the same time. But I think as long as you are not doing things that are not safe, because obviously safety is critical in everything that we do. That's been my introduction to engineering and DevOps and all of that.
Yeah. So are you vibe coding, or you said you trained yourself to be traditional, engineer, but what do you think about vibe coding? Have you been doing a lot of vibe coding, or?
I think it accelerates design cycles. So instead of just doing mockups, you can actually do clickable prototypes. So I think it's just a tool in the, in one's repertoire of how well can you communicate your vision to, in my case, it's my co-founder or to the any of the agents that are building the rest of the software and integrating it to the back end. So I think right now most people probably do any vibe coding mostly with the front end. The back end infrastructure is fairly hard to get to. I think that's relevant to your podcast. I think MetPlum and Phenomenal have a really interesting connection going with FHIR resources, right? So MetPlum is an open source EMR, and Phenomenal is kind of this interface communication layer that is able to use natural language to connect to FHIR resources. And so some of the projects that we're working on is as building an open source teaching EMR to help people just get feedback and practice their clinical skills. And that's some of the technologies that we're utilizing.
Yeah, that's great. And I love both MetPlum and Carrie. We actually had Carrie on episode of a podcast, so check it out. It was a great conversation. We may actually be working together with MetPlum and Carrie on a platform, which is basically letting folks kind of like, to your point, the back end, everybody has to reinvent their own plumbing. You're not going to be able to build a house as quickly. And I think there's a lot of people out there that have a lot of great ideas, but they don't want to have to deal with how do you connect to FHIR? How do you build a smart on FHIR app? How do you do the right, hookups here and there to just make it all functional and to enable your vision, right? So I think there's an opportunity for people to come together to build a platform like that. So that's actually something exciting that I'm working on, but also looking to partner with people like yourself as well. So if you want to join, please reach out. So Paula, so let's go into the primary care a little bit on the workforce stuff that you're working on, specifically on the quality. I've been in the quality measurement space for a while. I know that it's problematic, right? All the quality measurement we have in the industry is like retrospective. Primary care measurement is not, I don't think there's like great measurement on primary care. And particularly, I had a personal experience with this through my children's, they were diagnosed with ADHD, and we were trying to find a provider to get a prescription for them for ADHD medication. And essentially it was like super hard to do that, right? And super hard to find somebody to even get that. But it's also like when we finally did find somebody, we had to schedule visits that were like ongoing. So an ongoing treatment, probably very similar to primary care, where you want to see the patient in an ongoing manner. And just in my experience, I happen to be responsible for quality measurement for a large health plan. And I know those measures very closely and very well. So like the ADHD measurement only required 2 follow-up visits in a year for ADHD, for them to be considered ADHD under control managed, which is preposterous, right? Like that's ridiculous. Like that's nothing. But that's where we are in terms of quality measurement. It's a very low kind of bar for certain measures, and it's a very high bar for other measures. But it's like kind of just something that has been put together. What are your thoughts on that, and how are you approaching that kind of stuff? Like, what do you think applies to primary care?
Yeah, I think that's a great question. I really think a lot about that. And I mean, ultimately, the problem that I'm trying to solve is around having visibility of how do people do in their practice? Like who's struggling in what domains, and how can we support people to become better? I bucket this into the quality improvement space, but we really don't have good ways or frameworks to think about the quality around the individual themselves. What we often follow is like payer metrics or business driven metrics, which are often process measures. I think obviously there are things that really critical around clinical outcomes and patient experience. And, primary care quality surveys are trending towards what patients value and how their experience has been impacted because it's a relationship driven enterprise. An area that is generally doesn't have good business models around it is why it's neglected is how can we support people who deliver care? And so, like for example, in your case, you were looking for someone who can take care of your kids' mental health condition. Us having insight into who is the best person to handle that is really difficult. So the bar is really at the credentialing or like the schooling level where people got a diploma and they're allowed to do a bunch of different tasks and, like treat ADHD or prescribe medications. But that's pretty much as far as we get. What I think would be fascinating is to look at how other industries approaching skills intelligence. So for example, I don't know if you've seen Anthropic Economic Index. They've put out a report earlier this year around how Anthropic is thinking about skills and what's going to get augmented. And
I think it's what you're talking about.
so I think it's very similar. And the idea is that Anthropic basically looked at all of the traffic and the conversations that happen through their platform and try to understand what tasks are people wanting to accomplish with their technology. And then they're taking the tasks and categorizing them into skills that are required to complete those tasks. And so you can kind of abstract away the skill of visual pattern recognition both across like photography interpretation or radiology interpretation. And it kind of cuts across different industries that people utilize certain skills to complete tasks. And I think it would be really interesting to take that approach to healthcare quality. And so if you look at the task of like ADHD management, what skills go into doing that? And then how do we measure that? Not with the goal of checking boxes, but with the goal of understanding which clinicians need support with specific skills. And the whole reason is that we're thinking about workforces because we have huge workforce bottlenecks. There's not enough doctors. We have the shifting workforce composition where you have non-physicians becoming increasing part of the workforce. And, I'm all about team-based care and supporting everybody who's involved, but people just have different training. So for example, like nurse practitioners there's been a boom in schools that are able to grant basically degrees without much in-person training. And so people just haven't had the practice and the repetition of the skills the way that a clinician goes through medical school and residency and a bunch of rotations. The differences are vast. And so instead of And there's also a lot of turf war going on around, there's some doctors that don't like APPs and APPs don't like doctors and whatnot. But at the end of the day, we're all trying to help patients and do the right thing. And so, how can we, instead of looking at what schooling one came from, how can you actually look at what skills are needed to accomplish certain tasks? And I think this is where connecting things to technology becomes really relevant because you can actually look at clinical notes and documentation and abstract away the skills that people are exhibiting and the competencies that they show, and then actually be able to map how good is each clinician at different conditions that they're treating or different competencies that they need to exhibit for, let's say, appropriate referrals or antibiotic stewardship or other things that don't have neat structured data points, but we care about as a society, as an industry.
Yeah, and I'm sure that's also important because you really want to be able to benchmark against these, you know, automated or agentic solutions that will be coming out. And a lot of times, the only way you can say, oh, yeah, this is actually improving. Like we've had this with AI Scribes, right? I don't know if you've been following this conversation, but they actually had a study that came out that said AI Scribes are not actually saving physicians any time. They've just transitioned the activity that the physicians are not just spending, they're not saving people time in terms of putting together the documentation or reviewing it. They're saving the physician time in terms of not having to dedicate time away from talking to the patient, but they're still spending that time documented. They're just doing it asynchronously, and then they're reviewing the output, and then there's downstream processes that take place, right? But it's still an improvement, even though it's not necessarily the low-hanging fruit that people have been thinking it is. And I think it's probably the only way we're going to truly be able to identify the benefit and the value that these tools are bringing is if by having these benchmarks in place that you're talking about. Because if you don't know that it takes a provider, 15 minutes to schedule every appointment during the day, how can you then build a tool that reduces that if it takes 2 seconds for the person to get a text and click yes or whatever? Yeah, for sure. I think there's a lot of specialties that there's no way we're going to be able to keep kind of the momentum that's been going on. And then I think as a country, we're at a place where we're spending a third of our GDP on healthcare. That's unsustainable now. And tech.
Yeah, I love the question. I think I dedicate a lot of my time in helping others thrive in primary care, whether it's people who are founders. I run a mentorship fellowship. We've done that for a couple years, graduated 8 fellows to date. I support my colleagues in helping bridge that technical knowledge gap. Just enjoy, I think, sharing what I learn and being available to others building in primary care. So feel free to send them my contact information. They can reach out to me. I'd be happy to continue the conversation.
Yeah, check out Paulius on LinkedIn. You post very good articles all the time. You're on my top subscriber list. And what I love about your stuff is that you're very focused and you provide information that's not just generic, but actually actionable to this area. So thank you very much for your time. And you can check out of the FHIR podcast on every podcast platform. And xprimarycare.com is your company, right, Paulius?
That's right. Yes. Great to chat with you, Gene. Thanks for having me. Take care.
Thank you. Take care.